Well, welcome everybody. Thank you very much for joining us to talk a little bit about options for treatment in Waldenstrom's, particularly in third line after treatments with BTK inhibitors and chemotherapy with rituximab have failed. And I'm joined with three of my colleagues. Exciting to have Monique Minnema joining me, Christian Buske, and Jorge Castillo. So all of them real experts in this area. And so love to get their thoughts and perspectives on how best to manage patients. So maybe we'll just start off getting the perspectives of each of my colleagues here. If you've had a patient where you diagnosed them with Waldenstrom's, they needed treatment, you gave them maybe initial therapy with a chemotherapy such as bendamustine and rituximab, or maybe you gave them a BTK inhibitor as frontline therapy, and then second line, you use the other agent as your regimen, and now you've got a patient who still needs treatment. What's your next step? What do you typically do? So, Monique, I'll ask you to start off. And in your practice, what's your kind of go-to next step?
Well, thank you, Steve. Well, I must admit, so you will get the European version of third line therapies, and as you know, there are some more restrictions here, and especially the Netherlands are very famous for their restrictions. So I think in an ideal situation, I could get my hands on some BCL2 inhibitors like venetoclax in a small program in the Netherlands, and I was really enthusiastic about the drug. So I think the high response rates and the way patients are feeling under this treatment, for me, that would be an ideal third line treatment option. But in the Netherlands, the program stopped, and we are not able to provide this to our patients. And in that sense, I think we are then have to use proteasome inhibitors, and in that case, only bortezomib is available in the Netherlands. Sometimes because bendamustine is a treatment that has a limited period. Sometimes a patient can be in a long remission. And sometimes we can repeat an alkylating therapy for them. So that can be a third line option. But also the newer BTK inhibitors, I think, are very interesting also in this regard. Also, patients being not responsive anymore to ibrutinib or zanubrutinib. But again, that's not an option for us to go in the Netherlands, because I think they are not EMA approved and they also not reimbursed. So our options are quite limited. So repeating something that has been effective in the past or new mode of action is our way to go, but our options are not that great.
Right. Well, thank you. Christian, is that a similar situation for you, or is it different in your area of Europe?
No, I think it's, we are all under European law and approvals of the EMA. So it's very similar in Germany compared to the Netherlands or other European countries. So I think what Monique said, we have really to take into account. So the treatment options we have third line are really limited. So despite all the advanced progress we have seen in the development of new treatment strategies in Waldenstrom, it's quite amazing that already in third line we see our limit. So so what we do, I think first, because we have so limited treatment options, the first is, and I think Monique also mentioned it, to see whether we can repeat something which was already used in this patient. So when such a patient got rituximab chemotherapy and he had a long duration of remission, why not repeating it? Of course, we have to look for cumulative toxicity. So, for instance, when we would reuse bendamustine, we perhaps come back to this later. But of course, you could think about DRC, for instance, or bortezomib DRC, and vice versa. When this patient had ibrutinib, long duration of remission, then our chemo as a salvage treatment. Why not trying zanubrutinib? So you try to manage it in some way with the tools we have for first and second line. And then what we do in Germany is what we have to ask the payers individually for each patient is venetoclax, a single agent based on Jorge's data. I think it's a good way to go. Or as Monique said, bortezomib, rituximab, for instance, as a salvage treatment. And most importantly, probably, we would really always encourage our patients to look for clinical trials. I think Waldenstrom is a rare disease. You in the US, you have the WMNet with excellent clinical trials. We in Europe have the European Consortium for Waldenstrom with great trial activities. So we would always try to convince the patient to join a clinical trial in this, in particular in these late lines of treatment.
Christian, thank you. Jorge, I think in the US, there's obviously a bounty of riches, if you like. So what are you thinking in your practice?
Yeah, no, thank you. So when I see a patient in that clinical situation, I always divide the discussion in two groups, right? What we can do with standard therapies and what we can do in clinical trials. I think I agree with Christian in the saying that these patients are really ideal candidates for clinical trials for the reasons previously exposed by my colleagues here. So standard therapies, I think everybody has talked about them. We do have pretty much all the 3 different protein inhibitors available here or to treat patients with Waldenstrom's, bortezomib, carfilzomib, and ixazomib in combination with rituximab. In patients who have failed or progressed on a covalent BTK inhibitor, typically we do not offer a covalent BTK inhibitor again because there's a resistance. But if the patient stop therapy because of intolerance or toxicity, I think in that situation it would be very reasonable to consider and probably prefer to try a novel or a more recent generation covalent BTK inhibitor. We have some experience with venetoclax as well in this setting, and we are using now pirtobrutinib because it's approved by the FDA for other indications. And there's some data presented from abstract form. There's no peer-reviewed manuscript just yet. But in patients in whom really the treatments options are very limited and they're not candidates for clinical trials, we have been able to get pirtobrutinib in a compassionate use manner, and it has shown the efficacy reflected what we have seen in the clinical trials as well. So I think those are our standard treatment options, and we will discuss those with the patient, pros and cons, and educate the patient for them to make an educated decision. In clinical trials, as of late, we had this iopofosine 131 agent that the data was presented yesterday. It looks very promising, but obviously a peer-reviewed manuscript is important to understand the toxicity, the durability of the benefit, and other issues related to any type of treatment that we provide our patients. And we do have some actual trials that we can offer patients. At least at Dana-Farber and other centers, we have treatments with pirtobrutinib and venetoclax in combination. We have antibody-drug conjugates like loncastuximab tesirine that we are actually in a clinical trial currently. We're going to open soon a study with epcoritamab, which I think there's another study in the Netherlands opening in relapse setting as well. Actually, very similar designs. So I think there are a number of options, and we have now the BTK degraders, and we also have the new generation BCL2 inhibitors that seem to actually be effective even when venetoclax is not working anymore. So there's a number of different options, and all these options are available for patients. So we sit down with the patient and review the good and bad things about each approach, and that's the way we kind of approach the situation.
Yeah, very valuable. So, you just mentioned this interesting data, and from what I understand, this leucoposamine I-131 drug is actually fast-tracked now for approval, both FDA and EMA. So that may be an agent that shortly already is available for management. And again, as most of you know, response rates were good. They were actually kind of in the mid 70s with major responses, kind of, if I remember correctly, was kind of like 61%. And it actually looked quite durable, where the responses actually out to 8 months, the majority of the patients, I think, again, at least 3/4 of them still responding. So where do you see that fitting in? Do you see that as a useful agent and something that we're going to be using in the near future? I don't know, Monique, if you want to take a stab at that.
Well, I can try, but I must say I haven't seen the data in detail as well. And I can imagine there perhaps was some pancytopenia as a side effect for this drug. So that's always something, if you use it in earlier lines, that you have to take care of, because if a patient stays in a pancytopenia, then perhaps also other therapies are more difficult to provide to the patient. But sure, and also especially the one hit idea is I think quite interesting for patients instead of daily pills or a daily treatment. So I think that's very interesting, and I think at the moment as second or third line treatment would be an ideal setting, but to bring it further up, I think we need much more data.
Fair enough. Christian, any thoughts from you?
Yeah, I think, we just, at least in Europe, I think you in the US, you are more in a luxury situation. We just emphasize that the treatment options we have in later lines are very limited. So I think every new approach is more than welcome. Yeah, we have not so much in later lines of treatment. What I like with this approach is it has really a different mode of action. And we know that B-cell lymphomas belong to the most radiation sensitive cancer we know. And, we have these approaches also in follicular lymphoma. And I think it has really a distinct mode of action, very different to the mode of actions we have with immunochemotherapy, with BTK inhibitors. So very complementary. And yes, I would really welcome this approach. Of course, Monique is correct. We need validating, confirming data. But you mentioned the results. I think the median number of previous lines was 4, when I remember correctly. So very strong data. So when they hold true, I think it would be a very interesting treatment option after our, let's say, backbones, immunochemo and covalent BTK inhibitors at the moment.
And Jorge, just to get your thoughts, you mentioned there are actually quite a plethora of other agents out there, and your trials, loncastuximab, for example, antibody, bispecific antibodies, are all in the same spaces. How do you see this agent? Kind of harkens back to Bexar days. How do you see that fitting in?
Yeah, no, that's a good question. I think, I think my initial reaction is always good to have another treatment option, right? I think that's bottom line. That's a big thing. However, when I counsel patients in terms of treatment options at any time, I always review all the good things and the bad things of the treatment, right? So I think the good things about iopofosine would be that it's a limited duration treatment, right? You get 4 infusions, and then you're in a lapse of about 2 months, and then you're done. So that's actually a good thing. The infusions are relatively quick. Really, they don't provide any infusion reactions that we're aware of. So, and the efficacy data, at least in terms of the depth of response that was obtained during the first 6 to 9 months of therapy, seems to be reasonable and very interesting. All right, so all that is, I think, those are the good things. The aspects that are sometimes the devil is in the details, right? So the medication as of now is given by nuclear medicine. So I do not know really how applicable it's going to be in the community. Might actually be restricted to academic centers that have nuclear medicine, specialists and facilities to be able to provide this medication. Number 2, the patient is kind of radioactive for about a week, right? So they need to be in their own room, away from the family, toilet and their own, silverware and, meals and things like that, right? So that might not be too much of a problem. And then the pancytopenia issue, the cytopenias are real. I mean, there's a number of patients who actually needed transfusions, in the first place. And obviously the durability, the duration of that side effects, how long and how deep, I think we don't have a good understanding based on the data that was presented initially. And I think that will be key to understand that. And again, I think at the end of the day, the durability of the response is the key here, because when we think about pirtobrutinib or venetoclax, we're thinking about maybe 2-3 years of a median progression-free survival, currently without the need of transfusions, for example, right? So we will need to see that durability of the response with these agents. And this is, in the intermediate line or long term, but in the long term, I think one of the concerns that we had, with the isotopes is actually stem cell damage, right? And actually, is it possible that, we create some myelodysplasia or some other problems that will not be seen, until a few to several years later? So I think, all as time goes by, we should be able to see those outcomes, and I think that will clarify in my mind a little bit more where this agent will fall into the whole, sequence of events.
Yeah, thank you very much. So, now looking a little to the future, I think immunotherapy is certainly everyone's super excited about that. And so, Monique, your thoughts on bispecific antibodies? Those are starting to sneak into frontline therapies of a variety of different B cell, plasma cell disorders. And now, as we just heard, in clinical trials in patients with Waldenstrom's. Your thoughts on where that's going?
Well, I do have high expectations of this. And in fact, we are going to do a clinical trial with one of the bispecific antibodies in relapse setting in Waldenstrom patients within the HOVON group. And yeah, I think in Waldenstrom's disease, we have this niche that we can go for small molecules. And for example, the BTK degraders or the non-covalent BTK inhibitors, but also go to the immunotherapy corner. And I think the data, there are not much data on Waldenstrom's yet, but I think as we see how well it works in the other types of non-Hodgkin lymphoma, I'm quite enthusiastic. But again, we need to do the trials to know exactly where it will go and what the duration of response and response rate will be.
Oh, thank you. Christian, maybe to ask you in a similar vein, so CAR T is kind of the buzzword for lots of B-cell malignancies. Do you see that having traction in Waldenstrom's?
Yeah, I think we again and again see patients who really have an aggressive clinical course. And I think it's a pity at the moment that we have no access, at least in Germany, to any clinical trial which allows inclusion of Waldenstrom patients into a CAR T-cell trial. And I think this is bad, actually. It's a pity because, again, there is a subgroup of patients behaving clinically very aggressive, which would be for sure candidates for CAR T-cells. And we know from let's say, case reports, so a smaller series of patients, that CAR T-cells can be active in Waldenstrom. They are feasible. They can induce remissions in heavily pretreated patients. So I think it's for sure worth to be tested within clinical trials to speculate how well this works. I think we need much more data. And of course, CAR T cells have the difficulties also in diffuse large B-cell lymphoma or follicular lymphoma, that they are less flexible, let's say, than bispecific antibodies. So I think in the long run, the bispecifics are the more attractive approach, a more important approach for Waldenstrom's. But as Monique says, we need for sure clinical data. Who knows what happens? Waldenstrom is different. It has a CD20 negative malignant population, so it's different than follicular and diffuse large B-cell lymphoma. But my expectations is that the bispecifics will fly much better than the CAR Ts. But again, for a distinct, perhaps smaller subgroup of patients, it would be really worth to test this approach.
Yeah, thank you. And you made a very important comment there about the two populations of cells that are typically seen in Waldenstrom's patients. So Jorge, your thoughts, because you've got a lot of experience in your trials now with loncastuximab. Tell us a little bit about exactly what you're targeting and kind of what your initial impressions are related to that drug.
Yeah, I mean, obviously, I cannot talk too much about it without breaking disclosures. What I can tell you is some of the data will be presented at the workshop meeting in October by my colleague, Dr. Shana Saroshik, who's the primary investigator for that study. I think suffice it to say that we have treated probably about 7 or 8 patients, and they seem to be responding. I think that's pretty much what I can say. Without giving too much away. We're targeting CD19. CD19 seems to have a wider umbrella than CD20, specifically for Waldenstrom's. So for that reason, we're interested about that. I think epcoritamab, is a very interesting agent. The study will be open hopefully in the third quarter of 2024, and I think you guys should be opening it very shortly as well, right, Monique, in your setting in the Netherlands. So I'm really hoping to see that the responses there. We don't have a lot of data in bispecifics in Waldenstrom's. Actually, we have no data, and I think these 2 studies will be very key in understanding that. Now, CAR T cells. I mean, I think they will be effective, and there's some initial data that they are. Specifically, the more experience we have with patients who have transformation to aggressive lymphoma, and then CAR T cells have been exposed. Patients have been exposed in that setting, and the Waldenstrom responds very nicely to the CAR T cell. So I mean, we do have some preliminary data, and then some purely Waldenstrom patients. I think there have been some case reports out there published as well. Now, there have been 2 CAR T cell programs that were aimed at Waldenstrom's, and then both kind of falling through. The first one with Kite, they decided to close that program. The second one with Mustang Bio, the program was decided to be blocked as well. So really, as Christian said, we don't have a program specifically dedicated to Waldenstrom's with CAR T cells, but I think that's actually necessary. Now, talking about the target, just the final thing, I think there's a specific company out there, which I'm not going to mention the name, but they're working on actually a bi-targeted CAR T cells in which they're going to target a B cell and a plasma cell, a marker at the same time with the same CAR T cell. And so we are preliminary conversations to maybe the third's a bliss, right? The third's a charm, and then we can get a CAR T cell program running for Waldenstrom.
Yeah, thanks. So maybe the last question, and whoever feels like they want to take it can take it, is what about autologous transplant? We used to have that as kind of a therapy that we would be thinking about in those aggressive, badly behaved Waldenstrom's patients in this setting. Where does that fit in? Or is that entirely gone by the wayside now?
Well, I must admit, it's not gone in our center. It's still exactly the same indication as you described, Stephen, is the Waldenstrom that's not behaving indolent, but very aggressive, early relapses. And you have the feeling that you are done with all your therapies within 4 years' time. And for us, autologous is still an option that we sometimes use. We do it for the age up to 70 years. So for many Waldenstrom patients, it's not feasible due to an age limit. But it's something that we still perform in patients, but not that much anymore. But it's still out there, yeah.
Well, Christian, one more. Oh, go ahead. Christian, give your comment.
Yeah, I would say yes, it's not dead, but it's really rarely used. So normally you would use it. Autologous stem cell transplantation is more stressful for a patient than CAR Ts. And so we really reserve it for later relapses, where, as Monique said, where we have a clinically aggressive course, but we would always prefer to give before BTK inhibitors and probably also our chemotherapy. And when you have a transformed Waldenstrom, at least in Germany, you are open to all therapeutic tools which are approved in diffuse large B-cell lymphoma. So as soon as you have a proven histological transformation, you are open to bispecifics, to CAR Ts, whatever. So then we would probably go more this direction. But yes, for individual patients where you don't have a secondary transformation and which behave very aggressive clinically, it might be an option. But I think it's losing ground, I think.
Jorge, maybe I'll ask you a final question. And that is, we used to have a kind of a mantra that if you had a good response to a treatment in the sort of earlier lines, going back to those treatments could be a consideration. But we've just spoken about a lot of new and promising kind of things. So do you think that strategy is over?
That's a good question. I don't think it is. In the right setting, I think it could be very, very valuable. Just to give an example, we run a clinical trial with dexamethasone rituximab, and these patients actually is getting to the 10-year mark and needing treatment now. 10 years, right? So he's like, I'm talking about all this excitement about these newer treatments, and he's like, well, doctor, I mean, why did we do the same thing again, right? And I'm like, well, you know what? It's 10 years. I mean, yeah, why not, right? So it's reasonable. So when it's reasonable and you think that you will not expose your patient to a higher rate of unnecessary toxicity, then I think, and you have a really, really solid information that the patient did very well in the first place, then I tend to try it again. Now, with the caveat, and always tell the patients this, right? So the caveat is, I cannot guarantee that you will have exactly the same, degree of benefits, right? It might not be as deep, it might not be as prolonged, but it's definitely something that I consider in the right setting. Now, I mean, what is the time threshold that you consider good or bad? I think that depends very much in the line of therapy and who the patient is and things of that nature. But if somebody, let's say, got exposed to a frontline treatment and they got at least 5 years of benefit, I think that's something that we could potentially consider again.
Well, thank you. Those are really great insights from all of you. So appreciate your time, and thanks for those that have taken the time to watch this. Thank you very much.